My name's Dr. Warner Carr. I'm a allergist and clinical immunologist with 20 plus years of experience. And I am currently, the last 20 years, down here in Southern California in a clinical practice. We also have a very busy research center, Southern California Research. And I have had interest and have seen numerous patients with mast cell diseases over these years. Mast cells are kind of central to allergic diseases. So it's almost a natural transition as an allergist and clinical immunologist to take care of patients with mast cell disorders. Mastocytosis is an example of a quote unquote mast cell disorder. When you look at mast cell disorders, it's kind of a very broad term, and it just basically means that this cell, the mast cell that releases chemicals like histamine and leukotrienes and prostaglandins, that it's not working normally. Mastocytosis actually has five different subsets, and there's subsets within those subsets where there is a mutation in the cell that actively turns it on. And it's kind of hijacked the allergy reaction. So it's as if a person is continuously having a low level allergic reaction. And that's in the absence necessarily of an actual allergic reaction. If you could imagine a light switch on the mast cell itself. And when it has an allergic reaction, it clicks on that light switch and it has a reaction. In mastocytosis, that light switch, that mutation, turns the cell on constitutively, always activated. And this results in patients having reactions like anaphylaxis. There's a lot of hives, there's a lot of GI symptoms. And this is a disease that has really significant impact on patients' quality of life. And with the risk of anaphylaxis, it could actually have an impact on their quantity of life as well. So it's an important disease that's a rare disease. Well, we're in a new era right now with mast cell diseases, and in particular with mastocytosis. Again, I said there are different subsets of mastocytosis. The worst case scenarios are like leukemia, and those should be treated with a hematology oncology expert with skill set in managing these like leukemia mast cells. But in the less severe, like an indolent or even, smoldering, or even patients that don't have the mutation, that light switch being turned on, but they have a mast cell disorder, quite commonly, it falls into two categories. The first category is symptomatic treatment. As I stated before, things like histamine and leukotrienes are released, so we use antihistamines, anti-leukotrienes, and we just treat the symptoms. We actually now have a medicine, avapritinib, that will target that mutant light switch, if you will. It's called c-KIT. And that is the trigger, the enzyme. That's where the mutation is. And there is a medication now that can actually target the source and kind of quiet those cells down and turn that off so patients aren't having as many symptoms. So if you treat it at the source, they don't have symptoms, or you could treat the symptoms with antihistamines and a variety of other different medications. I think the mastocytosis control test is a very important test. It is a test that looks at patient-reported symptoms as well as other things that tells us how we are doing objectively, and some of it is subjectively, but reported by the patient. So it's a patient's perception in managing these patients. As an aside, quite commonly, you ask a patient, "How you doing?" And they say, "I'm doing great." Well, what does that mean? How frequently are you having symptoms? Oh, I'm having symptoms every day. I'm doing this. I'm rescuing myself continuously. It's just that they've really gotten used to suffrage, and we're not doing a very good job. So having a test with multiple components to the test that's easily administered, able to complete it in the matter of seconds to a minute, and having something objective that can help me manage those patients. Many patients with mastocytosis are being controlled by their disease. My goal is to control the mastocytosis so the patients can do what they want in their life, giving them the control back. And having something like the mastocytosis scale, this questionnaire, this activity score, helps me have something objective that I can follow with multiple metrics. Physicians can easily implement this into their practice. Health systems can easily implement this into their system. It could be administered to a patient while they're waiting in the lobby. It's a very simple questionnaire that they complete, and a score is rendered. And based on the score, it gives you their level of control. I would add a couple of things. First off, you're not going to find mastocytosis if you're not looking for it. So when patients come in with recurrent or chronic symptoms and it looks like they have allergy, don't forget to look for mastocytosis. You could start with a very simple screening blood test. It's not always 100% positive, but the serum tryptase is a very simple screening blood test that providers should be ordering. If you have a patient that gets stung by a bee and has an exceptionally severe anaphylactic reaction, or has an anaphylactic reaction to anesthesia or other areas, if it is something that we can do is to increase awareness. Mastocytosis is a rare disease, but you will never find it if you're not looking for it. So I would encourage people to be ordering serum tryptase levels and screening for these patients. And then if something is unexplained, please send these patients to an expert in managing, either an allergist, most commonly an allergist to start with, or a hematology oncology doctor. There are a variety of hematology oncology doctors that manage mast cell disorders, especially on the more severe side, but it's usually an allergist clinical immunologist. So if you don't look for it, you're not going to find it.